everybody, and welcome to the second series in our roundtable series of critical care paramedicine. And with us today, we have a very special speaker. I've known this guy and most of you probably know him for quite some time. He speaks all over the world. And today we're going to be talking about respiratory physiology and mechanical ventilation.
Steve LaCroix, as Penny said, some of you may know me I recognize some of the names that had signed up, so that's great. I've been a respiratory therapist since the late 70s and a paramedic since the early 80s. I've been an expert witness in over 130 medical malpractice or EMS litigation across the U.S. I've spoken at many conferences as far as Australia, Hong Kong, Alaska. I was just at that earlier this year. So, and I'm still employed. I work for a company as their director for clinical support. I do a lot of the training of the reps and for customers having to do with respiratory products. So, and most of you may have known also that I taught at St. Pete College for quite a number of years. So that's a little bit about me. All right. Well, as with any presentation, we've got to have objectives, and you're going to see these. I'm not going to sit here and read these to you. I think y'all can glance at them real quick, and you're going to pick up on the title of what this is all about. So we will talk about a little bit of anatomy and physiology and get a little more deeper into the physiology. But one of my goals for this is to pique people's interest in some of the little more deeper physiology and the whys things happen. And one of the things that I've noticed over the last couple of years, I've been tutoring people taking the National Registry. And one of the things that comes out in that, one of the test questions, or a number of their test questions, they talk about oxygen saturation. And you should not be giving, in most cases, high flow O2 with somebody with a SAT of 94 or greater. Where this creates some confusion for me is a pulse ox is inherently inaccurate. There's a lot of inaccuracies built into it. Is if we talk about, and which we will here in a few minutes, we're going to talk about the oxyhemoglobin dissociation curve. And a little bit of understanding that will give you an idea where that weakness is by following that guideline. But we don't rarely, if ever, talk about that. I'm not going to get into depth. You can do a whole class on that, but having an understanding will make you think that maybe that's not a real good hard and fast rule if I understand that. So I want to kind of pique people's interest today to get a little deeper. So some questions to think about. Now, I'm not looking for an answer for these right now, but as we go through this, keep these kind of things in mind. Like, what is VQ? What's a VQ mismatch? Is it essential for effective gas exchange? Well, if I'm not sure what VQ is or what a mismatch is, then you don't have a good understanding sometime of why somebody could be hypoxic even though you're giving them 100% oxygen. How can a patient have a good pulse ox and still be hypoxic? That's one of the main themes of today's course, is that if you got a person on a ventilator or you got a person on non-invasive ventilation or CPAP or BiPAP, how can they have a good pulse ox and still be hypoxic? How does that work? And why can a patient be hypoxic and still have normal respirations? People get a little bit confused between the difference between ventilation, respiration, and oxygenation. Why is negative pressure ventilation more efficient than positive pressure ventilation? I assume everybody that's watching this today is breathing negative pressure. And now you're going to come in and you're going to do positive pressure ventilation, which can have some negative effects totally on their own. So these are the things I want people thinking about as we go through today's class. So we're going to talk a little bit about the respiratory system. A couple of quick bullet points there. I think everybody on this today understands some of the basic stuff there about bringing oxygen in to the tissues and removing carbon dioxide, which is a byproduct of cell metabolism. And there's a bunch of other functions that the system does. We talk about acid-base balance. We talk about, clearing the airway with, the little cilia that are making, so there's a lot of things that the airway and breathing does. So I don't want to harp on those, because I think everybody probably knows that. So when you're looking at the upper respiratory system, is some of the things that we want to look at is some of the functioning of it. Obviously, we want to be aware the tongue is the biggest part of airway obstruction. And as we go down and we talk about the people have loss of muscle tone, swelling, things that we may have to, trauma. And I can use myself for an example, is my epiglottis does not close very well. Some of you may know I had throat cancer. The radiation kind of messed some things up. And I have a tendency to aspirate. That's one of the major problems on like ventilator patients, and they end up with VAB, ventilator-associated pneumonia, is a real common. If you're on a ventilator, it's been my experience, at about the 72-hour mark, there's a good chance you're going to come down with a VAP or some other respiratory problem. That's why the therapists are always eager to get these people off ventilators and that type of thing. So we have to be able to look at this, the upper airway, as what kind of adjuncts am I going to use, the OPAs, NPAs, different advanced airways, from intubation to supraglottics to extraglottics, that type of thing. And then looking at and listening to what stridor is. And you hear that with maybe a child or a small infant, the inspiratory stridor. And we start telling the difference between an inspiratory shortness of breath and an expiratory shortness of breath. And some of that can be clinically important in the upper airway. So the lower airway is, this is where there's no gas exchange in most cases. And the more we add to this area called dead space, we run into a lot of problems. I've seen people add different things to ventilator circuits, and you make the circuits longer. And all we've done is increase the dead space. And the more dead space you have, the less usable air that you can get. You actually want a good alveolar ventilation, which you cannot measure directly. And we'll spend a little bit more time, looking at that. And then we talk about wheezing. Is it an inspiratory wheeze, expiratory wheeze? Can you have a cardiac wheeze? All those things are true. One of the things, and some of you folks may remember this Dr. Pell, when he used to come and do lectures in Pinellas County CME. Unfortunately, he passed away a couple years ago, but the guy was absolutely brilliant about assessing patients. And he said one of the key things is which direction are they having trouble breathing? Do they have trouble getting the air out or having trouble getting the air in? He told me that there was only two important questions on your first assessment of a respiratory patient. A, are they alert? And B, which direction are they having trouble breathing? Because he said if you're alert, you're in distress. You're not in failure. And we'll get a little bit more into that, of why that is and why that's important. The relevance, is this going to be somebody that I'm going to put on a CPAP, BiPAP? Am I going to bag them, or am I put them on a ventilator? So basically answering those two specific questions, you know a lot about your patient. So he had a great way of explaining it. And then we get down to the alveoli, this is where, respirations are taking place. That's where gas exchange is occurring. That's an external, as they call it, respiration, where internal is actually at the cellular level. Anything that interferes with that, that's going to talk about an A to A gradient, which we'll talk about soon. That's that alveoli to arterial gradient. Is there anything interfere with that, like a pneumonia or any kind of a disease process where we get a buildup there, or a thickening, or a damage like this, like for COPD and emphysema and stuff like that? You can give them all of the oxygen in the world and ventilate them all you want. If that gradient is being impeded, they're not going to do well. So that's why we look at those types of things. So the advanced takeaway here is, if you got crackles, is you're looking at probably an alveolar problem. That's where your fluid and stuff kind of build up. And so if we think about it, what kind of a takeaway if I understand that I've got these crackle type sounds is I'm going to have to try to recruit areas that don't have that. That's why you're seeing the big thing with CPAP and PEEP and BiPAP. I had a doctor at a cadaver lab that I was working in saying that if you're not using PEEP when you're bagging somebody, he just said, you're just flat doing it wrong. Because if you're not recruiting alveoli, because there could be a shunt going on, there could be dead space going on, or some sort of impediment of gas exchange, everything else is going to fail. So as you can see there, some of the basic physiology of there we go, is for the capillary, where the gas exchange is going to take place. If we don't have a good blood flow going there, if there's a shunt that's causing the blood to not be there, or if there's any type of a problem that prevents that A to A gradient, as I said before, we're going to have a problem. So it diffuses to the capillaries, very, very thin membrane that it has to go through. And you're going to use the positive pressure of the oxygen molecule and the CO2 molecules to actually make this exchange. And if that's not going on, then bad things happen. Driven by partial pressure, that's that gradient. So the more partial pressure we have in the oxygen, the more it's going to get in. That's if there's no impediment to that happening. So as you can see there on the screen, you got basically, I always describe to my students as little grapes, is if there is, and we hear that VQ mismatch, that's the ventilation and the perfusion. Is the gas flow and the ventilation matched? Or is one of them missing? That's where you run into problem. So if you got somebody, say, with a pulmonary embolus, your VQ mismatch is going to be a problem because the blood flow is not matching up with the grapes. So therefore, we have an increased dead space and we run into a problem. So how would we treat that, say, in a pre-hospital setting or even a critical care transport? You think somebody's got a PE, is you're going to have to try to recruit more of the grapes, more of the alveoli. We have a lot more than we normally need. We can recruit those. That's where that CPAP, PEEP, BiPAP type stuff will come into play. So if you've got somebody that has poor oxygen, their SATs are bad, and there are medics now that do blood gases. Even if, of course, critical care transport, you just need to be able to read a blood gas because you're going to get those results prior to your transport on some of these patients. At least you should. And there are devices now where you can actually do pre-hospital ABGs. I think there's a future in that, especially if my argument about the pulse ox is, anybody grabs onto that, that maybe having like an iStat type thing where you can actually measure an ABG, you can really be much more accurate in your assessment and what you're doing. So if you've got somebody that the lungs are acting normal, they got good chest rise, they got good breath sounds, but their oxygen levels are really bad, we think about that pulmonary embolism that may be interfering with that VQ mismatch, and so sometimes there's not a lot that we can do about it, but there's a lot that they can do it at a facility for sure. So respiratory control, and I'm sure everybody's seen this before, is really driven by the CO2 levels. CO2, as you know, turns into carbonic acid if we don't get rid of it. And then what does that do? That creates and makes your pH drop. You become acidotic, drugs don't work well, organs don't work well, and people die. I mean, it's just that simple. We have to be able to manage that. So I've heard it for years. People talk about hypoxic drive theory. I, for one, think that is an overblown type thing. When I first became a respiratory therapist, again, back in the late 70s, at the end of shift change, or at the end of visiting hours, we had to go around and check everybody on O2 to make sure that the family members didn't turn the O2 up and was going to mess up this hypoxic drive and we're going to find dead people in the morning. I never saw that ever happen. Now, I've asked this question at multiple conferences on 3 different continents. And I've asked it to doctors, RTs, medics, whoever will listen. Have you ever personally seen somebody stop breathing because you gave them oxygen? And so far, nobody has seen that person. And I could show you some research that shows that that's a theory. It may have a little bit of an impact, but they're not going to stop breathing. Now, but we also have to worry about oxygen toxicity. And I can tell you, in EMS, as compared to some other places in the country, in the world, they don't do their CPAP and BiPAP and oxygenation with 100% oxygen like most of the agencies in this country does, because of the harm that oxygen can cause. So we're kind of between that rock and a hard place. Is that I think someday you're going to see blenders on transport units so that you have a better control of what the FiO2 is going to be. But again, for this slide here, we're talking about what drives it, and that's going to be the different parts of the brain that causes that to happen. But we know that certain things, certain injuries, head injuries, spinal cord injuries, drug overdoses, COPD patients, trauma patients, and stuff like that are going to be impacted in their ability to move air. And when I say move air, I mean ventilation. Don't confuse ventilation and oxygenation. So where critical care paramedics must master, and these are just my thoughts of what things that more advanced level paramedics that are going to be handling more advanced patients. And I think that this can slide over into everyday paramedic care to a certain extent too, is upper airway is a stridor problem. You've all heard it before. It's that upper airway, inspiratory in most cases. And the problem is positioning, adjuncts, intubation. Normal vitals can be misleading. So especially in these small children and babies. I used to work in high-risk deliveries as an RT and spend a lot of time in the NICU, is that these patients go bad quickly. So when you have stridor, there's an airway problem, generally some airway swelling, or it could be a foreign body, but you've got a serious problem that even though their vitals may be fine and they're compensating okay, we just don't know when that's going to change. The lower airway is more of the wheezing, the bronchospasm. What do we do? Bronchodilators. We love albuterol, Atrovent, Duaneb, that type of thing. Getting into steroids. There's a lot of things that we can do. Alveoli is going to be your crackles. That's when you're moving towards the, maybe a little bit with the bronchospasm, but also bronchodilators can come into play. But this is always also a CPAP, BiPAP candidate. Dr. Pell, one other thing he also shared with me, that regardless of why somebody is having trouble breathing, regardless of their distress level, is what caused it, what's the underlying pathology, those treatments should be considered. Because remember, you're not curing or fixing anything. We're buying time. We're trying to deliver patients in better shape. If we're doing an interfacility, we want them to arrive the same way we found them, hopefully better, that type of thing. Now, perfusion, if you got a patient that has clear lung sounds, but they're hypoxic, well, how well are they perfusing? Is the alveoli getting the oxygenation and the blood flow? And it's not shunting, and that VQ mismatch is there an issue with that? So if everything is going good, we're looking at a perfusion and we're trying to treat either a pulmonary embolus or shock. One of the things that we have a tendency to do is not look at the preload and the effect that some of our treatments, like if you put somebody on a ventilator or you're bagging somebody or you're doing the positive pressure, the impact on the perfusion that those therapies can do. So we can actually add to the problem by the way that we treat them. So control altered mental status and hypoventilation, central nervous system issues, ventilatory support is we're not going to fix those things. Now we can make them worse by not treating them correctly, but we generally can't fix them. Paramedics must think the patient is short of breath and instead ask which component of the respiratory system is failing and how do I fix that specifically. Just because somebody has short of breath doesn't mean it's a respiratory problem. Could be multiple things that are causing it. We're looking at is what's failing. Is it that gradient? Is it, and I'm going to spend some more time talking about the oxygen hemoglobin dissociation curve, not that you can fix it and not that you can actually calculate it unless you're doing blood gases and stuff, but having an understanding of why that's important can make a difference in your patient. Mastering respiratory physiology is a must, not just following protocols. I think we have reached that point in the profession, at least in my opinion, is that following protocols, I always take that they kind of number protocols, 1, 2, 3, 4, 5, 6, and then people have a tendency thinking they got to go 1, 2, 3, 4, 5, 6, is what's happened before you got there, what's the effects of what you're doing, and using that clinical judgment and making a decision of what's appropriate based on what you've determined is the underlying physiology, the underlying pathology of what the problem is. I have people tell me, well, paramedics don't diagnose. I totally disagree with that. Medics do diagnose. You don't diagnose, people die. So it's really that important that we understand the underlying part of what's going on. So basic definition, oxygenation and ventilation. Oxygenation, that's your PaO2 and your blood gas, or your pulse ox, your SAT. And it does give you an idea of whether that A to A gradient is working. Now, ventilation is looking at your ABG or your end-tidal CO2. Much more accurate test to go by. But if I've got somebody that let's say their end-tidal CO2 is in the normal range between 35 and 45, but their oxygen saturation is 78. Obviously, that's an oxygenation problem, but not a ventilation problem. If they're moving good air, and that number is going to stay the same. And it could be vice versa, where you got good oxygenation, but their end-tidal CO2 is way off, either very high or very low. So we're looking for what is the underlying problem before, like with Dr. Pell's thing about how alert are they? And his argument there is if you walk in and they're breathing 40 times a minute and they're working hard, but they're alert, he argues that they are compensating and therefore they're in respiratory distress. So I'm going to travel one pathway. If I walk in and that same patient is breathing 40-something times a minute and they're starting to fall asleep a little bit, CO2 narcosis, they're past CPAP, BiPAP, that's a BVM or a ventilator. And so look how much you know in just the first few seconds of your assessment, or if you're transporting a patient and you start to see those changes, you have to move away. It was interesting. I was working with some respiratory therapists at a local hospital that was struggling with a BiPAP device. And what I realized after talking with them, because they knew how to use the device worked fine, and they knew how to use it. They were trying to be too aggressive and was putting it on a patient that it wasn't indicated for. The patient had actually gone from distress into failure, and they were trying to do something like a CPAP device, which does not help you breathe. CPAP does not help you breathe, doesn't do anything for you to breathe, that kind of thing. So once we talked about the patients that they put it on and understand, okay, this is what's going on, then they stopped having a problem with that device because they were picking the right device for the right problem. And that's just a very key thing. And then you calculate minute ventilation. Basically, if you have a tidal volume, that's the amount of air you breathe in on one breath, and multiply it times the respiratory rate, that's your minute ventilation. So you'll have to learn, since some of you may be involved with dealing with ventilator patients, what some of these terms mean and why. And then when something happens, where would I make my adjustments? That type of thing. So I see that falling into the purview of the medic. Our tidal volume, you see, a lot of respiratory therapy definitions or terms, the letters are backwards. They'll say that's tidal volume, but most people would say opposite of that. So imagine them being a little backwards when you read them. Respiratory rate. I've had people look at respiratory rate and think that's respirations. Respirations is gas exchange. Respiratory rate probably should be ventilatory rate, the amount of volume that you're moving in and out of your body, not the gas exchange is taking place, but something else to add a little confusion. Oxygen doesn't fix a ventilation problem, and a ventilator won't fix an oxygenation problem. Know the difference, or your treatment will fail. So which are they having, or could they be having both? Absolutely. But if I've got a patient that their CO2 on their blood gas, or their end-tidal CO2 is in the normal range, but their SATs are low, it's an oxygenation problem. And how do we attack oxygenation problem? There's really only two ways that we can do this. We can increase the FiO2, which we know is in learning, it can be risky, or we put them on some PEEP. PEEP will make your oxygenation more efficient. So I can stay in the lower FiO2 by doing it more efficiently, by recruiting more alveoli, by making the alveoli larger for more surface area to have gas exchange. I don't have to go to those higher numbers. So important, the minute versus alveolar ventilation. There's a company out there called ResMed. You may have heard of them. I don't work for them, so this is not an advertisement for ResMed. But one of the machines that they have a BiPAP machine that actually you adjust the tidal volume based on alveolar ventilation. And I was trying to figure out how did they do that, since alveolar ventilation cannot be directly measured. So if I've got a machine that's telling me you're giving alveolar ventilation, how does it come up with what that tidal volume is going to be? So when I contacted the company. I had a question for you, and they have some clinical people. And they said what they do when you put your settings into the machine, you have to put the patient's height, how tall they are. It's got a little computer in there, and it will calculate based on your height what your alveolar ventilation should be. Now, the alveolar ventilation is your tidal volume minus your dead space. So that's your usable air. So that machine will adjust while the person's sleeping, automatically will adjust on its own to maintain the calculated alveolar ventilation, because that's where the work's being done. So you could have a tidal volume that's high, but you got a lot of dead space because you got some airways that are collapsed down, you got some alveoli that are collapsed down, so you're not getting a good amount of alveolar ventilation. The average adult's going to have about 1 cc or ml of dead space for every pound of lean body weight. It's kind of a guessable way of coming up with alveolar ventilation, but they do it with a machine. We have to understand what alveolar ventilation is and why some of the pathology that you may be running into with congested patients, shunt patients, pulmonary embolism patients, that your alveolar ventilation is where the problem is. So it's important that we think about in those terms. So the alveolar ventilation is the tidal volume minus the dead space times the respiratory rate would tell you their minute alveolar ventilation. So it can be measured directly. I already mentioned that. Why is this important? A patient can have a normal minute ventilation, but inadequate alveolar ventilation. They're moving enough air, and you got them on a machine, and you've dialed in a tidal volume for them. And that's what the machine is pumping out on every breath. However, if they have something that's impacted alveolar ventilation, it may not be enough. I had an interesting thing happen here recently having to do with dead space. Is a hospital called and said they were having trouble ventilating newborns, preemies. Had to do with mask fitting and all that kind of stuff with a BVM. And what I realized, the mask that they were using had about, if I remember correctly, somewhere around 14 mLs of dead space. Well, for a preemie, you know how much their tidal volume is? About 15. So they had added 14 out of 15 mLs of dead space. Well, no wonder the baby's not ventilating good. You have a bunch of dead space that you have added to the airway because of the mask design that they were using. So, after explaining that to them, they ended up going with a different product to do it because they were moving enough air, but they had too much dead space in the equipment that they're using that made it where there wasn't enough alveolar ventilation for the baby to survive. And they apparently had at least one that didn't have a good outcome, and I attribute it to the mask. So minute ventilation, to adjust minute ventilation is pretty simple. Is you're going to either change the rate or how many breaths they get or the volume that they get. That's what you're going to do. So pretty simple. Adjusting oxygenation is changing your FiO2. And with all of the research out there these days having to do with oxygen toxicity, hyperoxicity, I think you're going to see people backing away. But there's some patients you can't do that. So how can I increase their oxygen? I mentioned it on one of the previous slides, is you've got to do, that's where the PEEP's going to come into play, positive end expiratory pressure, because you're recruiting, you're dilating, and you're going to have better gas exchange. So it's kind of a balance between doing those two things. If the CO2, our end-tidal CO2 is rising. Now, I think everybody probably watching this understands end-tidal CO2. If you're bagging a patient, or even if they're on a ventilator, and you start to see the CO2 or end-tidal CO2 going up, what do I do? Generally, what you're going to have to do is you're going to have to increase the minute ventilation. Either you're going to have to bag them or change the rate on the machine to go to a faster rate, or you're going to have to increase the tidal volume. The problem with increasing tidal volume, and I imagine people have heard this, that's why you're doing lower volumes with your BVMs, at least that's the recommendation. When I first started as a respiratory therapist, when you put somebody on a ventilator, the standard starting tidal volume was somewhere between 10 and 12 mLs per kilogram. And if you do the math, that's going to come out with somebody that's going to be right around about 1,200 cc's per breath. And we never worried about it. But we know that higher positive pressure like that can cause damage to the lungs, drop your blood pressure, cause all kind of bad things. So now, what's the standard now? If you go look it up, the standard is going to be somewhere between 5 and 7 mLs per kilogram. They call that lung protective ventilation. You'll hear that term, if you're dealing with the respiratory therapist. They don't always think about it with a BVM, but they think about it with a machine, even though the effects can be just as bad. So you're seeing now people going to smaller bags to meet the standard of what the tidal volume is. We don't need that big, large, because most of the adult CPR bags that are sold out there are probably somewhere around 1,500 cc bags. There's some that are a little higher. If you look at that EPIC study for traumatic brain injuries, Dr. Dan Spate was the principal investigator on that, and I know Dan. I sent him an email and asked him about the tidal volume and the impacts that it can have on brain injuries. And he said, yeah, your bag should not be any bigger than 1,000 cc's because that's over too much volume when you're doing that. So it's it's pretty interesting when we start looking at comparing tidal volume and alveolar ventilation, and then calculating some dead space. Am I getting and improving that type of ventilation? So ventilation versus respiration, I think I've hit that enough as far as gas exchange versus air going in and out. Pulmonary vascular problems is the pulmonary embolism, unperfused alveoli, for whatever means. You get the people with emphysema, they have the bull eyes and stuff, where they don't have good gas exchange, pretty common. Mechanical ventilation factors, this is something, if you look at those circuits there, and you look on the right, that's a BVM with an extension on it. If I add anything, if you look at the two circuits on the left, the one on the bottom that's got the red, is they've added something in line to do an end-tidal CO2 detector. All they did, in addition to being able to measure the end-tidal CO2, they added dead space. When I first became a respiratory therapist and took ACLS for the first time, the first drug out of the bag for off the drug cart for a code was bicarb. We used to give them 2 amps of bicarb right off the bat, because the theory was they hadn't been breathing, CO2 is going to be up, pH is going to be down, to give them the bicarb. And then what did we do? We start bagging them. So now I blow the CO2 off. What did their pH do now after I gave them 2 amps of bicarb? Now they're very alkalotic. What do I do about that? I can't suck it back out. Well, what we would do is we would purposely add dead space to the ventilation circuit to purposely increase their dead space so their CO2 level would go up to match the high bicarb that we gave. And then we'd slowly over time have to shorten the tubing to stay up with it, until somebody said, why did we give the bicarb in the beginning with zero downtime? Because we created a bigger problem by giving the bicarb. But that was the first drug that came out, and we had to play with the dead space to balance out their pH. Now, if you look at that CPR bag on the right, does that tubing between the bag and the circuit and the valve, does that make dead space? And the answer is no. Dead space is only part of the circuit where you both inhale and exhale goes through it. They're going to exhale out the side of that valve. Their exhalation does not go back into the bag. So that would not be an increase in dead space. So anytime you add something to a ventilator circuit or any kind of an airway, and we're adding dead space. Now, for a lot of adults, you can add that end-tidal CO2 detector. Is not going to be a big deal. But if you're doing this with children or doing this with babies who have their very little bit of, tidal volume, and you're adding dead space, it's significant. For those that have ever used colorimetric end-tidal CO2, you add that in, that's dead space. For a baby, though, you have to use the very tiny one that has like 0 dead space in the device itself. So dead space calculations and understanding that is extremely important. So normal VQ is basically balancing the alveolar arterial gradient. You look at the blood gas analysis to determine how effectively oxygen is passing from the lungs into the bloodstream. That's what I want to know. So they basically take the FiO2, and they're going to have the blood gas, and then they're going to compare those two to see where it comes out at and what number it would be. So is the VQ ratio measures the balance between the amount of air reaching your alveoli and the amount of blood flow in the lungs. So they'll take and if you look at the math, which is right there, there's a standard of 0.8 is comparing 4 liters minute ventilation and 5 liters minute perfusion. It should be 0.8 to come out with a proper VQ. So that's what we're trying to do. And you can take the FiO2 that you're using and you compare it to the oxygen level on the blood gas. If they are close, within a 0.8 ratio between those two numbers, then they're fine. If it's off, then you know you've got some sort of a ventilation perfusion mismatch. So it occurs when airflow, ventilation, and blood flow perfusion is the mismatch. In a perfect lung, air reaches the alveoli, blood reaches the surrounding capillaries, oxygen moves into the blood, CO2 moves out. That's what we want to see happening. When they're mismatched, these things fail. So it's most often going to be a shunt. Perfusion is present, but no ventilation, but ventilation is reduced. So the example would be like a pneumonia, COPD, pulmonary edema type things is, remember I talked about this, some kind of a obstruction or blockade that's preventing the gradient to happen is going to give you that VQ mismatch. So this usually is going to improve with supplemental oxygen because you raised the oxygen percentage obviously going in. So it's going to be higher oxygenated when it goes. What does get in will have a higher oxygen percentage, or their PO2 and their blood gas will be higher. The effects of this, blood passes poorly ventilated alveoli. And so the oxygen is going to drop. Now you're giving them plenty of oxygen, but it's having trouble getting through and mating up with the blood. When those things happen, you've got a mismatch. So if we don't have blood gases and having some of the information, it makes it very difficult. When you don't have those things, you have to make certain assumptions when the patient is failing or having a problem. Is what do I do? Do I raise that FiO2 up even though they tell me the SAC could be good? May not be good. You got to judge and assess the whole patient to see how well they're doing. So dead space, VQ mismatch, ventilation without perfusion. So when you see hypoxemia, the CO2 clearance is impaired, end-tidal CO2 or PaCO2 gap widens. That's the difference between if you did a blood gas and you look at the CO2, and then you look at the CO2 and your end-tidal CO2. So if you're picking up a patient and you're going to transport them and they hand you a blood gas, and you see, you'll know what the end-tidal CO2 is, and then they're showing you what the PaCO2 is. If that gap, the difference between those numbers is widening, then you know the mismatch is getting worse, and oxygen is not going to fix that. So I got a little chart there that when you have a person who is having some of these issues, if it improves with oxygen, then the VQ mismatch is low. You're able to compensate for it by giving them O2. If it doesn't improve with oxygen, now you're looking at a shunt. The blood's not getting there. If they have clear lungs with hypoxia, probably a dead space, we're looking at a pulmonary embolus. And if the CO2 is going up and hypotension, there's an obstructive process somewhere. So we're thinking about how would I attack these things as their ventilation starts to fail, because we're seeing an increase in end-tidal CO2. We're not going to have another blood gas made because we've already left the hospital. Is how would I manage that? Is I would have to increase my ventilation rate, increasing the tidal volume and the minute volume to be able to do that. So in the field, you don't diagnose the mismatch with numbers, you recognize it through patterns. We're looking at lung sounds. We're looking at pulse ox. We're looking at end-tidal. How are they responding to the O2? I'm kind of amazed sometimes, and it goes back to some of the lawsuits that I've been involved in over the years, is how often medics do not document a response to something that they've done. They had a problem, they applied something, maybe following a protocol, but don't document what happens. Even the National Registry, if you look at the some of the graphics they have that circle where you start out with, coming up and you're making assumptions of what it is. You're coming up with a thesis of what it is or a theory, and then you work your way around to evaluate what steps you've done to make a change. So how do we know if we don't look at the response of what we're doing? So signs of a low VQ shunt, some of the field findings, back up to that, is hypoxia with a low sat, crackles in rhonchi. Rhonchi is really due more to congestion. One way to tell about rhonchi is have the patient cough. If the noise changes or moves, it's going to be phlegm or mucus. Increased work of breathing and poor response to oxygen alone. This is what we're looking at, is that we have a low VQ. There's a shunt problem. So what would I do about that is I may have to increase the oxygenation. I may have to work a little bit, maybe not so much on the tidal volume, but I could use PEEP. If they're on non-invasive ventilation, I could use BiPAP or bilevel. These gives me some other options. And if you got a patient on a ventilator and say you've got them on a CPAP or BiPAP mode, ventilators do have those modes, and I start to have this issue, do I go to a more controlled ventilation mode? They're not able to do the work. To me is whenever somebody says, I always do this or I never do that, you're going to be wrong somewhere. You're going to have to look at and individualize your changes in your therapy. So the low VQ plug flowing past the alveoli are not being ventilated. I think I've beaten that up quite a bit. And this is where CPAP and BiPAP would be most effective when used early. And that's, these patients don't always call us early, or you're picking the patient up and you're moving them. They could be, going down the drain by the time you get there. The earlier that we approach and have the appropriate therapy, the better off they're going to be. So improvement would be increase the FiO2 to improve the A to A gradient. I'm getting more oxygen across. And then CPAP and BiPAP, most effective when used early. So it would be simple as if I see they're having some of these characteristics, is to go ahead and increase the FiO2 and do the PEEP part of the CPAP and BiPAP, that's the exhalation side, to create the improvement. So field treatment, I just relayed that, so pretty straightforward. When improvement looks like is an increased FiO2 will improve the gradient, and the other one will do the recruiting of the alveoli. We're going to have better oxygenation and better ventilation. Pretty simple. If CPAP works, the problem was recruitable alveoli. The down part with CPAP, and I'm going to probably mention this a couple times as we go through, is CPAP actually increases the work of breathing because now you've got more resistance to exhale against. So if I've got a patient who's on that bump, they're in respiratory distress, and some of you may have seen this, you put them on CPAP and they get worse. They start falling over into that respiratory failure side because now we just increased the amount of work that they have to do to be able to breathe and to be able to balance their pH by getting rid of the CO2. That's why I'd be willing to bet anybody that's transported, probably everybody here's done it, transported a patient to the hospital on CPAP. What did they do at the hospital? I'll bet you it's close to 100% of the time they're going to go to a BiPAP device. And the reason that is BiPAP helps you do the work. It's actually a form of non-invasive ventilation where CPAP is not. That's the big difference. If I had the option, I would probably never put any of these people on a CPAP device. It would always be a BiPAP device. So if high VQ is the problem, air isn't getting to the blood, and some of the signs that we would see would be hyperventilation, tachycardia, hypotension's late, cool, clammy skin. You got a patient that's crashing on you. So if you had something happen suddenly, you're transporting the patient, and all of a sudden, suddenly, something like this happens. they starting to decline on you. If it's sudden like that, I would think PE, pulmonary embolism, until proven otherwise. Something happened very acute, came on fast. You listen, you got clear breath sounds. Your end-tidal CO2 is low. It's not being able to really get there and measure it because we have a lack of blood flow. So you're not going to get a good end-tidal CO2. And so there's some of the things I just listed right there. So a SAT can be deceptively normal. Again, the inherent inaccuracy of pulse ox. So your field treatment would be with high flow O2 to help maximize the available oxygen. Fix the perfusion. We might want to, fluid challenges in giving fluid. Consider vasopressors and rapid transport. We don't have a whole lot of pre-hospital treatment for a pulmonary embolus other than increasing the FiO2. And in addition to that, put them on a CPAP, BiPAP device to actually recruit other alveoli, get them into the game that still may be being perfused. That's one way to offset part of what the pulmonary embolus has taken away. So the high VQ isn't a lung problem, it's a circulation problem. I think you probably picked up on that. Oxygen is supported, but won't fix dead space. We've got to create more alveolar ventilation. I keep falling back to that. It's such an important thing to understand and to evaluate and then provide treatments that improves that. So it's about recognizing a pattern of good ventilation, but poor perfusion. Can't be measured directly, but it can be seen on assessment. The lungs are moving air, but the blood isn't showing up. And so if you're doing all the ventilation stuff correctly and the patient still continues to deteriorate or is not greatly improving, we start thinking about a perfusion issue. So all the changes on the ventilator that you want to make is not going to have a major impact on that. So we start thinking about perfusion. So some of the clinical stuff, oxygenation is primarily a VQ mismatch or VQ issue. So if they're ventilating okay, but we're not getting good oxygen, then it's an oxygenation issue. So we'll do the steps of increasing FiO2 or putting them on with PEEP. Ventilation CO2 removal is primarily a minute ventilation issue. If you got somebody that's breathing, maybe their tidal volume is good, but they're only breathing 6 times a minute. So your minute ventilation is going to be an issue. And I think everybody here knows how to correct that because we're going to bag them a little faster and a little deeper. So correcting a ventilation perfusion mismatch focuses on increasing delivery of O2, improving ventilation to underventilated areas, or restoring blood flow to underserved areas of the lung. The most common first-line treatment is supplemental oxygen. We shouldn't be worrying about, at this point, the oxygen toxicity, hyperoxygenation, that type of thing. You've got a failing patient that you have. It's like everything, if you probably ever learned in medicine, it's a risk-benefit ratio. What are you willing to risk to get the benefit? So positive pressure ventilation, such as BiPAP or mechanical ventilation, to treat the atelectasis, PEEP to prevent from closing. Those alveoli will have a tendency to close back down. Protect ventilation to prevent overdistension of ventilated areas. That goes back to the lung protective ventilation strategies, where you end up with lower tidal volume so that we don't create barotrauma or volume trauma and that type of thing. So it measured the difference between the alveoli and the artery, so the pulmonary arteries. So the gradient is those two terms there. It's the bridge between the alveolar oxygen and arterial oxygen. It exposes where gas exchange is failing. So if you have somebody that you're giving high flow O2 and you happen to have a blood gas and you see the oxygen is low on the, a normal PO2, PaO2 should be somewhere between 80 and 100 and say it's way off, so you've got a big gradient difference, then you know oxygenation is a big problem. So gas exchange. So now what am I going to do about it? And that's when you increase your FiO2 if you have room to do that, or you've got to put them on some kind of PEEP or something that's going to recruit. One of the questions, is it important to know and understand the A to A gradient and be able to calculate it in the field? Well, the answer to that is it's hard to calculate directly in the field without a blood gas. And as I mentioned earlier, a lot of people don't have it. However, even if it's not possible to calculate directly, having an understanding and the ability to estimate the gradient can make a difference. So you're doing all the right things, but they're still hypoxic. You're doing all the right things, but they're still struggling with their oxygenation. You know, all this type of stuff, we have to assume that there's something, and I know people probably hate that word assume, but you're working in a area that some of y'all may remember Pat Chappell used to say that we work in an ahistoric environment, because that's where you live, doing the jobs that you do, or once you leave the facility with your patients, you know, as things change, it's our job to monitor and make those adjustments. So a little chart here as far as the field interpretation. If the sats are going down and the CO2 is going up, basically we're talking about hypoventilation. Ventilation's the problem. What do? You're going to bag them and make sure they got a good airway. Pretty straightforward. That's the easy one. Sat going down and I've got a normal end-tidal CO2, there's a mismatch. O2 and CPAP. Increase the FiO2, add PEEP, which is part of the CPAP. Sat going down, end-tidal going down, we have a perfusion problem. Both of them are not measuring very well. So we have a high VQ, a lot of dead space, we're going to support circulation. Now, if it's a pulmonary embolus, that type of thing, it's going to be a problem that you might not have a real effective way of treating that other than trying to recruit. If your sats are normal and your end-tidal going down, hyperventilation. Not normally a critical thing, could be because the patient's excited, could be drug problems or whatever, but these are patients that may need to be sedated if they're on a ventilator, and they're also a mode of ventilation that they can actually breathe a higher rate than what's set on the machine, that type of thing. So they may have to be calmed down a little bit. So the famous oxyhemoglobin dissociation curve, you could have a whole course just on this. And if you look at the question there, how can a patient that has a high oxygen saturation but still show signs of hypoxia? How does that work? You know, and why should I understand that? And how do I know that there's something I should be doing about that that can impact the oxygen saturation? And we're talking about how the saturation is going to be at the cellular level. You know, so so the curve is an S shape. You're going to see a diagram over here in a second. It's showing a relationship between the partial pressure, the PO2, basically in a blood gas, and the sats. Okay, and one of the interesting things, it illustrates how hemoglobin binds oxygen in the lungs and releases it at the tissue. Think of it this way. When you inhale and you get oxygen going into the bloodstream, the hemoglobin really likes the O2. They're buddies. They're dating. They're getting along fine. At some point, they got to break up so that the oxygen get to the cellular level. There are things out there that interfere with the hemoglobin, the oxygen and the hemoglobin disassociation. You do it on every breath. Everybody does it on every breath. It's going to change that it's got an affinity for hemoglobin, and at some point it does not. If there's something that's going on that will not change, causing the hemoglobin and the O2 not to like each other, it's not getting off at the cellular level. So you could have all the oxygen in the world, but if it's not disassociation at the cellular level, the patient can't use it. They're not getting to use it at all. So that's where I think it's important. And there's a couple of things that's going to come up on this next slide. Now you see the chart there, that's your curve. If you look in the middle, the blue one, that's your normal curve. But the other two, the dotted lines, are also normal. And this, everybody's doing this, is if it shifts, the curve is going to shift left or shift right. And if you look at the things that are listed, the ones that jump out to me is pH and CO2. Remember, those are related. CO2 goes up, pH goes down. So where are we going to find most of the CO2 is going to be, and the pH going down is at the cellular level, because that's where it's being created. So it's going to cause the curve to shift left. That means the O2 is going to have, it increases the affinity for the oxygen. And then if you look at the other side, it goes the opposite direction. This is what we want normally to happen. So when CO2 goes up, pH goes down, it decreases the affinity of oxygen. So therefore, it gets off the hemoglobin and goes to the cells. And it's just the opposite when it goes the other way. When the decrease in the CO2, increase in the pH at the lungs, at the alveolar respiration, that's when it gets hooked on the hemoglobin. So if that makes sense, hopefully I was clear on that, is that if the patient's pH is dropping, we're not ventilating them very well, and their CO2 is going up, and the pH goes down, it's not going to get oxygen to the cells like it's supposed to. So the thing to walk away, unless we get into a more in-depth about the curve, is thinking that the pH, which the only thing that we're measuring now that can give us an idea is your end-tidal CO2. If that is up, we have to assume the pH is down. So there's going to be lack of an affinity of the oxygen to get on the hemoglobin. So now it can't get to the cells. So we have to make sure that we've got our end-tidal CO2, or if we happen to have a pH from a blood gas, we want that in the normal range, because it can affect whether the oxygen gets on the hemoglobin and whether it gets off. That's that disassociation part. So it's important, and you can get into the 2,3-DPG, you can get into temperature changes, but the ones that really jump out, at least to me, is the pH and the CO2, because we can get an idea of what that is by our assessment or from the blood gas, that type of thing. So it kind of this limits a little bit with the pulse oximetry limitations, which is going to be on the left side of the graph as compared to the partial pressure from the blood gas at the bottom. So it's it can be a little bit of an accuracy issue, but if you've got a patient that you're giving them plenty of oxygen, your FiO2 is fine, but they're still showing signs of hypoxia. The color's not good, short of breath, whatever they're doing, is look at your pH. And the best way you can do that is look at your end-tidal. If it's up, the pH is going to be down. I've got to balance that back out. You've got to ventilate them better, or you're going to impede the oxygen dissociation curve. So that is about the simple explanation as you can get. So blowing off too much CO2 can make oxygen stick to hemoglobin. So then if I overventilate them, then it's not going to get off at the cellular level. I still gave them plenty, but the CO2 is affecting its affinity to hook to the hemoglobin or not. So if you have a trauma patient being bagged aggressively, so look at those numbers. We got a stat of 100, end-tidal CO 25, patient becoming more altered. Well, what's happening is they're probably not getting oxygen to the cellular level. So I would look at that they're probably being hyperventilated. CO2 is down, shift to the left. Hemoglobin won't release the oxygen. So tissue hypoxia. And the only thing that's missing there, if you look at your SATs, 100%, patient's hypoxic. The CO2 is impacting whether it gets to the cells or not, or to the tissue cells. So that's why those things are so related that we have to have a good understanding of that's what's happening. So what's the issue with the National Registry recommending withholding oxygen to patients with a saturation of 94? They're not giving you the full picture. I've got to look and see what that end-tidal CO2 is as it relates to the curve. It's either, if I've got it too high or I've got it too low, it's either going to not get on the hemoglobin in the lungs, or it's not going to get off at the cells. So either way is a problem. And so very few times do we get that relayed to us to have that information. So I'm a little sketchy on that 94 as an absolute answer for these patients that are hypoxic. Now, this is something that you can do, which I think is really helpful, something that you can do outside of a hospital. It's the SF ratio. That's your SAT and FiO2 ratio. And what you're looking for is somebody that's hypoxic respiratory failure, because you're going to try to predict, is this patient okay on non-invasive ventilation, or does this person need to be bagged? Is this person going to fail? They need to be on a ventilator. So I can come up with some concrete numbers on how to do that. So, and if you look at these numbers here, if you do the ratio and you're thinking about, well, should this person be intubated and be on a vent, or should this patient, can I try them on a BiPAP device? And this is going to help you make that determination. So you take your FiO2 and you're going to multiply that times the SAT. And if it comes out to those numbers, less than 350, less than 231, less than 147, it's starting to tell you. So you take your SpO2, let's say their SAT was 90, and you had them on 21%, had them on room air. Divide the 90 or multiply the 90 times 0.21. Actually, you divide it. I'm sorry. Divide the 90 by 0.21, which would give you 428. That would tell you that the patient is safe enough to go on to a BiPAP device. They don't need to be on a ventilator yet. So again, you take that percentage, that 90%, and divide it by 0.21 equals 428 is going to give you that number. Now, here's a paper that was written back in 2011 in Journal of Critical Care. In conclusion, we propose that a simple index of SF ratio at the time of non-invasive positive pressure ventilation initiation could be used to identify patients at high risk of MPP failure. So that's telling you, is it worth trying that or is it not? So again, take that SAT, divide it by the FiO2. Again, the 0.21, 0.35, whatever oxygen percentage you're using, it's going to give you that number. And then you know what my next step is. Am I fine where I'm at? Do I want to be more aggressive or be prepared to be more aggressive? That's what I'd be using that for. So that one really has street value. So key values here is, do I continue to monitor this? I would say yes. You're transporting a patient, might be going a good distance. Could I simply do these over and over? Sure. Resource efficient diagnosis allows for the detection of severe hypoxemia in the absence of a blood gas. And it does help you detect early a patient that's deteriorating. And so you can see again on those numbers, as they go down, the patient is going from normal all the way to critical respiratory failure, hopefully you would intervene somewhere on that chart that either my non-invasive ventilation is working or it is not. Are they a candidate for it or they are not? So it's helping me make some of those early decisions. So reactive oxygen species, there's been a lot of talk about uh, giving too much oxygen and the harm that it caused. I mean, even if you look at some of the American Heart Association recommendations, you've got a patient that you've gotten ROSC. Now they want you to tone down the FiO2 to keep that sat in the 94 range because of the it's a vasoconstrictor causing more problems, and there can be some long-term effects. So how do we balance this out with the pulse ox, not overly accurate, making some of those decisions? Because we know if we go too far either way, we're causing harm. So basically, what is a free radical? Generally, it's an oxygen that has it's missing one of its electrons, so it's going to be radical. So what happens is these free radicals cause cellular damage. It's unstable, so it causes damage all the way down to the DNA, cell membrane, all kind of problems it can happen. So we'll call this reactive oxygen species causing tissue destruction. We know that now, probably have been knowing it for years, that if we give too much oxygen, oxygen is a drug, every drug on the planet becomes a poison at some dose, we're going to get these free radicals that will cause injury, and they termed it the reactive oxygen species. So it's harmful. And these are kind of the things that this is what you're going to see long-term wise, is causing, you know, what free radicals can do, the lipid paradoxation. They alter enzymes and structural proteins. They cause mutations, and the hypoxia injures cells, but sudden or excessive oxygen can also injure cells via free radicals. If you've got a patient that you had them on 100% oxygen and you're working a code, and then you get ROSC and you get this influx of massive amounts of oxygen, you're going to end up causing some of this toxicity and some of these reperfusion issues that occur for this large amount of oxygen coming into the system. So we're between a rock and a hard place here. Is when do I do that and when do I not? And you're being required to use not the greatest of measuring tools unless we move towards doing ABGs pre-hospital or during critical care transport. So oxygen-wise, we titrate, don't blast. We're trying to monitor this. We want to see the hypoxia. We're thinking about that A to A gradient. We're thinking about the oxyhemoglobin dissociation curve. A lot of things are involved here. So use the lowest effective FiO2 with your CPAP and BiPAP. However, I mentioned earlier, I don't think there's too many agencies out there that actually have blenders. So how do I do this? How do I adjust the FiO2 on some of these devices unless our transport unit is set up to do that, which I believe a lot of the critical care transport units are, but I know very few routine ambulance or routine transport trucks that have that. Reassess frequently. This is an ongoing thing. So we're making our adjustments. It's not one of these things I set a vent up and never touch it, or set up CPAP and never touch it, or BiPAP. Any of those things is a constant monitoring and making changes in these patients. Understand COPD and oxygen, the hypoxic drive. I categorize that as a minor issue. It can have some impact on the drive, but not significant enough. We got it in the back of our mind, but I'm not making a lot of operational decisions or treatment decisions based on that. So after ROSC, turn it down. And I think that's the message with the American Heart Association of looking at the SAT post code, is we have to make adjustments and turning it down to do that and not staying on 100%. But if you're using a BVM, what choices do you have? you basically got room air, or you got 100%, or somewhere close to it. We don't have a lot of flexibility. I think that's going to have to change or should change. So hypoxia kills in minutes, oxygen toxicity harms over time. We have to learn to manage both. And it's a constant evaluation, and having these thoughts in the back of my mind, I have to monitor and adjust these things. Unfortunately, and you've heard me say this probably 10 times now, is that we don't have the greatest of monitoring tools under most occasions. And I think that's why that needs to change. So understanding the difference between respiratory stress and respiratory failure is picking the correct modality. And you see that last sentence, applying the wrong modality creates what I call dysynchrony. If you don't pick the right therapy for the right problem, most of the time you're looking at something's going to fail. Like I was telling you about the respiratory therapists that were putting a BiPAP device on somebody in respiratory failure and then wondering why the device wasn't being effective. Is that we don't need to do overkill. We don't have to sedate everybody and put them on a ventilator, but understanding that difference is huge. And I mentioned earlier what Dr. Pell said about the patient being alert and not alert is the first key, and if they're compensating, I had a patient, obviously many years ago. Patient was a DNR, but he's wide awake, had lung disease, lung cancer, and was dying, but he's breathing probably 45, 48 times a minute, but he's alert. Now, of course, his heart rate was probably 4 times that. And I had somebody that wanted to deal with the heart issue. Well, I'm thinking, no. Why is this person breathing so hard and fast? Is he trying to maintain his pH by blowing off CO2? We didn't really do much of anything therapy-wise. What I would have liked to have done, and they did at the hospital, is they gave him an amp of bicarb because the cancer had thrown off his acid-base balance. And as soon as they did that, a short time later, his respiratory rate came down. He wasn't working as hard, and he was a lot more comfortable. But understanding that the fact that he was alert, breathing that fast, he's trying to get rid of CO2. And why would I get rid of CO2? Because I'm in metabolic acidosis, and that's where the problem is. And he's working his butt off to compensate for that. We could have caused a lot of harm trying to do something cardiac-wise, but I think it's an understanding of the physiology of what I'm looking at can make the difference. So the big difference, and there's the definitions, and I kind of mentioned this already, is that person that's alert, working hard, understands what's going on. We're thinking distress. When patients start to fall asleep because of the CO2 narcosis, that's a person who has gone over the cliff and gone into failure. And after that, we're going to go into respiratory arrest. It's just that simple, and that's what I'm looking for. So if you're transporting a patient they're in distress, but they start to have issues, maybe they're not quite as alert, that type of thing, is maybe that person has gone from distress into failure, and maybe that BiPAP, CPAP device is not going to be effective. It's dysynchrony. It's not matched up. This is a patient that needs to probably be, RSI, intubated, put them on a ventilator type thing. We have to know when I'm going to make that move. So the difference of the therapy, everybody knows about CPAP. And I've seen people debate this with me, but whether it's a form of non-invasive ventilation. When they say non-invasive, that just means they're using a mask. And we all know that CPAP's got one level of therapy. You're going to be on a CPAP of 5, 7.5, 10, somewhere around there. Can go higher, especially if they go on a ventilator. The problem is it makes the work of breathing harder. Now, all of us figured this out a little bit during the pandemic when we had to wear a mask, is that when I have to wear this mask and inhale and exhale through a filter, basically, the work of breathing is going up. Now imagine that I'm blowing air into your face at, say, 10 centimeters of water. I have to exhale against that higher resistance. That makes my work of breathing. And I'm sure some of you have seen patient, I mentioned it earlier, that you've had a patient who's in distress. I put them on a CPAP device and the patient gets worse, can't tolerate it. They're taking it off. Work of breathing goes up. We really made things worse because it's the wrong type of therapy. CPAP is something that you want to use for somebody that's got an oxygenation problem, not a ventilation problem. And some of your ventilators will have CPAP mode. They might have a BiPAP mode. They're going to have a number of other modes, as we'll talk about shortly. Now, your bilevel is a form of non-invasive ventilation. If you've never used BiPAP device and you ever have a chance to see them if they in the ER or some of the location where they're using a BiPAP, or if you know somebody that wears CPAP for a sleep apnea, if that person ever had a chance to go from a CPAP device to a BiPAP device, I'd be willing to bet they would change. Because you've got two pressures. You got your IPAP, inspiratory pressure, and you got your expiratory pressure, or EPAP. They're going to be different. Standing order might be you're going to put them on 10/5. The higher number is always the inspiratory pressure. Lower number is the expiratory pressure. In between those two numbers, it's called pressure support. Think of it going from the exhalation, the low number, to the higher number, gives you a kick to help you inhale. Therefore, it's helping you move air. And since the exhalation is a lower number, you got less work to exhale against. So you can see that if I've got something that's helping me do the work, regardless of the underlying pathology, what got me here, it's going to work better. And that's why when you get to the ER, if you're picking a patient up that came in from EMS and they were on CPAP, I'll bet you they're going to be on BiPAP. Again, I mentioned that earlier. So far, I haven't had anybody tell me that that's not 100% of what occurs just about everywhere. So it's one of those things that critical care transport will have. Now you're seeing EMS agencies that do have BiPAP devices because it's just flat out better therapy for most patients. Unless it's just oxygen, then the CPAP will work fine. So these are the kind of devices that you'll see for CPAP. That's a ventilator on the right. That's a CPAP device. And then that's a disposable CPAP on the left. The one on the left, really common in EMS. The one in the middle would be really common, say, in a hospital. And the one on the right could be for transport or in the hospital. So they have different modes on those, the one in the middle and the one on the right. But these are CPAP devices. Then if you look at a BiPAP device, kind of looks like some of the same thing. The one on the right's a V60. V60 is probably being removed from the market slowly. That's about a $16,000 item. Probably not going to see too many of those. But I can tell you, South Florida with Dr. Antebi, they got some grant money and they've put Hamilton T100s, I believe they got, on their transport units, which has a BiPAP mode, CPAP mode, and other ventilation modes. So we are seeing people going to do that, but you're going to spend a lot more money than you will with the other two. But having that technology and understanding why I'm doing that is extremely important. And why would I pick one over the other? I mentioned these earlier, inspiratory, expiratory pressure. There's going to be two. The bigger the gap, it should always be at least 5 points. Pressure support should always be at least 5. So the 10/5 type thing. If I want a little bit more kick, I would raise the IPAP. I wouldn't change the EPAP. I want at least 5, which is basically PEEP. 5 of PEEP is going to make it so that your airways, your lungs, and your alveoli don't collapse back down. Because every time, if they do that, every time you breathe, you have to do the work to pop it back open. So why not hold it open? So again, you could go from a pressure support of 5, or let's say I take my 10 and I run it up to 13. Now I've got a pressure support of 8. That's a little bit more of a kick. You're monitoring your patient. you're going to ask, how's that feel? Is this helping? That type of thing. We're not going to ignore them and see if that makes a difference. Now, every time I raise that, I do run a little bit of a risk. You have to measure that risk-benefit ratio. Is I want for them to get a little more help. I want to improve their oxygenation. But as those intrathoracic pressures are increased, there's a couple of things that can happen. One, I can cause barotrauma, damage to the lungs that way. I can overstretch the lungs and cause volutrauma. I can drop their blood pressure because it affects preload. And if they're wearing a mask and this extra air can get into the stomach, there's a good chance that they could vomit and aspirate. So as I change these pressures, there can be some negative effects to it. But again, risk-benefit ratio. I mentioned pressure support. So indications for this. Instead of, there's a whole list of them here, but to me, I kind of like what Dr. Pell said. It doesn't matter what the underlying problem is. If they're in respiratory distress, they're candidates. I don't have to make it any more complicated. You've seen all kind of patients like this. And it's also used for weaning them off of a ventilator. There's a whole weaning process that therapists will generally go through to get somebody on a ventilator. When I was working at a hospital, the goal, I had to go over to Lakeland Regional and help with patients that were having bypass surgery, and they wanted them off the ventilator within 12 hours. And so there's a whole process of weaning somebody, and that could be one of the steps is I'm going to change modes on my ventilator to go, say, from assist control or some kind of a control mode to a non-invasive mode would be a step to getting off and see how well they do. And then eventually they're going to get taken off totally. There's other tests that they would be running. And one's called an SBT, a spontaneous breathing test, to see if can the patient now do the work on their own. It's not a good idea just to yank them off the machine. So you can see all the different things, and you're all pretty familiar with these medical conditions, but all of them could be candidates and how well they tolerate it. And here's some of the interfaces. Interface is huge. And if you look at those pictures there, those are the types of different interfaces. Even the one on the bottom right is called a helmet or a hood. Not popular in the US, popular in Europe and maybe the Latin American countries. It's I know some companies that tried that during the pandemic, but it just didn't catch on. One of the interesting things, if you look at that picture in the center, that's got the whole face mask instead of a full face mask, which is the one to its right, is there's a push right now, and you might want to go and look at a webinar that was done by Dr. Anteri, Dr. Pepe, and a guy named Kyle. I can't remember Kyle's name. He's a respiratory therapist, paramedic, of using that kind of a mask and putting newborns, even preemies, on CPAP or BiPAP. And they're using that the whole face mask to do that. And they're starting, there's at least, I know of at least 2 EMS agencies that have written that into their protocol, that if a newborn baby, they're putting them on CPAP or BiPAP with that kind of mask. Because if you think about it, especially C-sections, which of course you're not doing those pre-hospital, but is a lot of times these kids are congested. So a little bit of CPAP or BiPAP, but most of our EMS agencies limit the age probably somewhere around 10 or 12 years old, not below that, even though there's no support of that in science, but you generally do not see that. But we may see that if that becomes prevalent of transporting babies and newborns with a mask that looks like that. And the interface is so important. If I don't have a mask that gets me a seal, if it doesn't fit right, it starts to cause skin breakdown problems, and that typically doesn't happen on an EMS call, but it can for long-term calls or patients that are being transported long distances or whatever. You can actually get skin breakdown, which according to Medicare and Medicaid, is what they call a never event. That's not supposed to occur. So you'll see respiratory therapists that will rotate different style of mask. So we typically don't see the whole face mask, but I think there might be a future in that. So it's going to be used to improve oxygenation. Pretty straightforward. Reduce work of breathing if it's non-invasive ventilation. We're not talking about CPAP here. We're talking about the BiPAP or a ventilator. Alveolar recruitment. We're talking about the alveolar ventilation. I can improve alveolar ventilation by putting them on a non-invasive ventilation. Correct hypercapnia, the high CO2, because it's helping me do the work or helping the patient to do the work. Avoid intubation if possible. That's one of the differences I see sometimes between respiratory therapists and paramedics. Respiratory therapist knows that they're going to have this patient a while. If they put them on a vent, it's going to be a lot more work. Sometimes you can't get them off. Sometimes they end up in a nursing home on a vent. So they're thinking kind of down the road. But remember, their world is respiratory. They're not involved in a lot of the other things. Where a medic will have a tendency, a person who's starting to fail, instead of using this type of device, they'll just sedate them, intubate them, bag them, and then put them on a vent. Is two different approaches to the same type of patient. You can run a risk doing it either way. I've seen therapists try to be too conservative, and the patient declined on them, and they were behind the curve. I've seen medics, sometimes I've read their reports, where they have gotten really aggressive when it may not have been necessary. So always and never does not apply here. So should be considered an option for any patient in respiratory distress, regardless of the underlying pathology. I should have put Dr. Pell as the quote on that. Absolute contraindications, when I wouldn't do this, is the patient can't protect their airway. Obviously, we don't put vomiting, if they're doing that, under positive pressure. Really bad idea. Any kind of facial trauma where I can't get a seal. Some of the relative ones would be they got a low blood pressure. They don't have really good hemodynamic stability, so I don't want to drop their blood pressure by using positive pressure. A lot of secretions. Or somebody that's actually fighting with it is probably not the best thing. And we really don't want to sedate these people and taking away their ability to breathe by doing that. So CPAP, just as kind of some ideas on settings, is 5 to 10 is a pretty safe. And when people have asked me, well, what settings do I start with? Staying out of the practice of medicine, since I'm not a physician, I usually tell them start low and increase as needed. Remember, as you make changes, as you go up, so does the risk. So I want to start low, work my way up. And so you start, say, out on 5, you would make sure that your mask is sealing, you're actually getting those numbers. You're asking the patient how does that feel? Is that helping? That type of thing. And then you could bump it up as you go. So the goal is to recruit, improve oxygenation. If their end tidal is good, they're able to do the work, it's just their sats are a little low, CPAP is a great option. It helps to reduce the toxicity if I can reduce the FiO2, which may or may not be an option according to where you're working. And it can cause an increase in breathing because of that resistance. In the BiPAP, I've seen everything from standing orders that starts out at 10/5. That's the bigger number is going to be your IPAP. I've seen on ventilators, they'll get up much higher than that. But remember, the ventilator's doing the work. EPAP, somewhere between 4 and 8. I think I would just kind of standardize it as 5. Pressure support, keep 5 numbers or 5 centimeters of water between the 2 numbers. Then you have that good kick that they're going to need. Too high of an IPAP can cause gastric insufflation, obviously create possible vomiting and aspiration, and it's also uncomfortable for the patient if we got too high of a pressure. Too low causes inadequate ventilation. The CO2 or end-tidal CO2 is going to go up. So it's not one of these things, set it and leave it. It's set it and monitor it and adjust as needed. That's too often, I've seen or I've talked to people is they want a standard setup. Tell me what to put it on, and they put it on that, and they never come back to make the change. It just doesn't work that way. Now, this one is probably one of the biggest areas where I believe people fail when it comes to CPAP, BiPAP, non-invasive therapy, called the peak inspiratory flow. Everyone watching this had a good lesson on inspiratory flow, whether they know it or not, during the pandemic. You put that mask on. Not talking about the politics, but we didn't like it for whatever reason. Even if you go back and look at some of the September 11th videos of the people on the big pile of rubble, and they had masks on, where was the mask in a lot of the pictures? It was generally on their forehead or on their neck. It definitely wasn't over their face. And people came up with a lot of different reasons. It was hot. It was claustrophobic. I believe what it is the difference in peak inspiratory flow. Humans have to have air at a certain volume and certain velocity to meet your demand. You go outside and run around the building a bunch of times, you're going to breathe harder and faster to try to stay up and compensate for the additional CO2 so our pH isn't falling. So now I put a mask on, and now I've got to pull that air fast enough to match my peak inspiratory flow. And I get a slight sense of shortness of breath, not difficulty breathing, shortness of breath. So now I go ahead and I put a patient on a CPAP or BiPAP device that does not provide the air fast enough. So if you're looking at a CPAP or BiPAP device, one of the things I would ask anybody that tried to sell me one is, I want to know, what's the peak flow? How fast is the air coming to the patient? On ventilators, they have knobs that you can adjust and change the peak flow. Because if you're not giving them fast enough on the vent, they will fight you. So that's one of the important things to check, is the flow for that type thing. So and I think there are devices, or in fact, I know there are devices out there that a lot of times cannot match the patient's peak inspiratory flow needs, and they will fight it, and they will not do well on it. So I think that's a key thing, a key question I would ask. And one of the ways that you can tell, if you happen to have a CPAP or a BiPAP device that's got a manometer on it, I think all of them should have manometers. If you got a manometer, then you can document the pressure. You can tell whether you got a good mask seal, but you can also tell about your flow rates, and I think that's probably key. If they inhale and the needle goes to 0, the peak inspiratory flow is not fast enough. A person in respiratory distress, the velocity has to be probably right around 65 liters a minute. And a lot of these devices will give you 5 of CPAP on 8 liters. How do I get from 8 liters to 65? A lot of them use it as a venturi. All y'all know about venturis, that if you narrow the flow, it speeds up. So that's what I would want to know, is if I put somebody on device X and they tell me to put it on 8 liters, 10 liters, or whatever they're going to tell you, what's the peak flow coming out the other end? Because if you're not getting close to 65 liters a minute, that's not the volume, even though the venturi does add to the volume. It's the speed that I want. And so if you look at that manometer and you got it on a patient, and every time they inhale, it goes to 0. First of all, you're not CPAP and BiPAP anymore, because pressure is supposed to be continuous. So I lost that. And now I'm not giving it fast enough. And then I wonder, then why do you want to rip it off? So I think if you walk away from anything, this would be one of the top 5 points of this presentation, is looking at peak inspiratory flow. It's that critical to be able to do that. So that's so it's not meeting their demand. Now, A lot of these disposable devices that are out there, if you put that on, let's say Michael Phelps, everybody knows who that is, the Olympic swimmer. I guarantee his tidal volume and peak flow he generates has got to be off the charts. If you put that on him, he's going to overbreathe it every time. Fortunately, he doesn't need anything like that. We're talking about patients with respiratory diseases, uh, 3-pack a day smoker for 30 years of non-filtered cigarettes. We're talking people who don't have that kind of ability. And then when I put a mask on them or something that doesn't provide it, and we wonder why they get, they want it taken off, or they do worse. They start to do poorly. We didn't match the therapy to the patient's problem. So when a patient inhales, I told you about that's what the gauge does. The patient will feel air hungry, and they will fight you, and they're going to want to pull it off because you have to have the ability to match their needs. You'll see double triggering. Triggering just means starting a breath on a machine. If you put them on a vent and you're not giving the flow fast enough, the patient is going to try to increase the respiratory rate because you're not matching it. So triggering is just starting a breath. That's a ventilator term, the triggering. Cycling is when it goes from inspiratory to expiratory. Like they'll start triggering more breaths because you're not giving them enough and they're trying to add more breaths in. So they're flow starved, not giving it fast enough. Just such a key piece of information. I just can't rate it any higher. And breath stacking. Breath stacking, if they didn't get a chance to get all the air out and another breath comes, some of you may remember, and I won't call it by name, but it was a CPR bag or a BVM that was red. And one of the things that it did is it slowed you down of how fast that you could ventilate somebody, trying to control rate. We don't want to overventilate these people. So if you try to do too fast, it would slow you down. And then when you look at it, though, there's a thing called IE ratio, the ratio of inspiratory time and expiratory time. So if I slow down, the inspiratory makes me inhale slower because I can't squeeze the bag as fast. I don't leave enough time to exhale. You should have about probably twice as much time to exhale as you do inhale. But if I take up most of the time in inhale, they don't get to exhale all the way. And then now here comes the other breath. I start getting breath stacking. And that increases internal PEEP. It creates all kinds of problems with patients when we do that. So that's why understanding flows and pressures is such a huge thing. And so we don't want ventilatory asynchrony. We want the device to match up to the patient's need. And when we, as the clinical people, do not do that, then we start to wonder why patients get worse with this. Sometimes they're just going to get worse anyway. We can't totally control that, but we can control the management of these devices because we're going to have a better understanding. So if the peak inspiratory flow is adequate, the breathing matches demand, reduces the work of breathing, less sedation. I've seen people that wanted to sedate a patient because they were fighting the machine. But if you go over and look at their numbers, you realize the machine is creating the problem. But they're sedated, not sedated yet, but they could have their hands tied down. They're fighting with everything because we're not providing proper ventilation by the settings that we're using. So that's something that you have to continue to monitor to make sure that they're not having an issue. So how to monitor the effectiveness of therapy? I believe everybody probably knows a lot of this. End-tidal CO2. CO2 is more accurate. If I can do a blood gas, obviously, we touched on that. We're looking at the SATs. We're seeing if these things are moving because of changes maybe in their dissociation curve or changes in their gradient. Even though I don't have an exact measurement, I start thinking about those things. Work of breathing, accessory muscle use, tachypnea, the heart rates are going up. They're working harder because there are ventilator settings where the patient is providing some of the breaths on their own without the use of the machine. The machine might be giving them a basic rate and they're adding to it. Mask fit, leaks, correct before changing pressures. That's one thing. That's why that manometer is nice. If I've got an alarm going off or something, is I'm looking for a leak. And if my manometer is not going to what it was before, I got to think I got a leak somewhere. Mental status. Remember, we talked about this a couple times. The CO2 retention because of fatigue, you get the CO2 narcosis, is maybe we're not eliminating the CO2 and have to change our settings so we're staying within those, within the appropriate numbers that we want for end-tidal CO2 or for CO2 in your blood gas. So common failure modes, worsening hypoxemia, recognition, the stats falling, and respiratory rates going up. Immediate action, increase the FiO2, increase the CPAP, maybe both. Adjust the EPAP if they're on a BiPAP device. And then we've got to really start to consider intubation, is that this is not being, they're deteriorating. So at some point, we're going to want to control the airway. Rising CO2 or fatigue, accessory muscles, we're watching how they're breathing. We're watching that end-tidal CO2 going up. We could increase the IPAP if they're on a non-invasive. Check their mask fit. Again, we might be moving towards intubation. Is this patient going from distress into failure? And if they are, maybe my CPAP, BiPAP devices is no longer appropriate, and I've got to do something more aggressive. Gastric inflation, obviously distended abdomen, vomiting. We got to lower that pressure so they're starting to get air again. And if this is non-invasive, their airway is not really protected. And again, an NG tube could be indicated. Hypotension, we got to look at drop in the blood pressure. Maybe your EPAP is too high. Remember I was talking about increase in positive pressure can reduce preload, therefore drop in the blood pressure. Mask intolerant, agitation, patient fights the mask. Once you've checked all the other stuff, you've checked, that they got a good seal, you've checked that the volume is right, that the peak flow is right, that type of thing is, maybe trying a different interface, if you have that as an option. When I worked in the hospital, a lot of times you would have patients that you would rotate different types of masks. Maybe it's a nasal mask, full face mask, whole face mask, different manufacturers sometime, but you wouldn't have that as an option. But sometime having alternate means does give you choices. High-flow nasal cannula is really something that has, over the last number of years, become a really big deal. Patients love it. They like it a lot better than all the other things that are out there in a lot of cases. These are flow rates. Remember back to the peak inspiratory flow rates of 60 liters per minute in adult, if not a little higher. It's going to have most of them are going to have a blender, so you can adjust the FiO2. The idea is to wash out the dead space. They're not getting rid of the CO2 like they should. So it's constantly flushing with fresh oxygen. Now, it doesn't really do any type of PEEP or CPAP. It does a little bit, but not as an independent therapy. But patients find this a lot more comfortable. Now, of course, at 60 liters a minute, it's going to have to be humidified and warmed. And this is where you run into an issue if they have to transport a patient, this is what a typical high-flow nasal cannula setup is going to look like. Now, there is a version out there that's an enclosed model. I think they got their FDA approval, would be much better for transport. I know some places where critical care transport has declined to take high-flow nasal cannula patients because they had no way to set this up in the back of a moving vehicle, that type of thing. So I think this is something, as if that device has come out or other ones get on the market, that everything is self-contained because of the humidification and the warming. It would be a great advantage to be able to do this. Patients, again, tolerate it much better. It is a special type of cannula. It's not your regular nasal cannula, but that's the interface, is just a cannula in the nose. But the fact is, patients tolerate it 10 times better than they do a standard CPAP or BiPAP if their condition allows them to be able to do that. So with this, the patient entrains room air, delivers FiO2, becomes unpredictable with low flow. A lot of the devices that you have used probably throughout your career, a regular nasal cannula, non-rebreather mask. Some of you may remember the partial rebreather mask. Venturi mask is there was always a certain amount of room air going in, and so the FiO2 is very unpredictable. In this one, if you look at the top of that picture there, that is your blender, and it's also got an oxygen sensor, so they know exactly how much that they're giving. The interesting thing about that one, that blender, and it's really hard to tell in the picture, at the bottom of that blender, which is at the top, there's a filter there. They're using what they call and it's by a company called MaxTech Venturi. I don't work for them, so my disclaimer there is you're able to do that without having medical air in your transport unit. Medical air in a hospital, they have oxygen, medical air, suction all lined up on the wall. This one is going to entrain room air from the environment, filter it, and it's hooked up to oxygen. That's how they can use a blender. That's what I would recommend to any transport unit, unless they have a setup where they have either a compressor or our medical air tank. Routine ambulance transports or rescue transports don't have that. But with this device, you could actually do it. So device flow meets or exceeds patient's demand. Remember I talked about the peak inspiratory flow? If you're starting out with 60 liters, you're going to be right there. Minimizes room air entrainment unless I'm using a blender that's actually purposely mixing it. And it's a stable FiO2. So you know exactly what you're giving them when they inhale, because I've got it all dialed in. Now, on this next slide, that's the one I was talking about. I don't quite remember the name of the device, but it's actually a totally enclosed high-flow nasal cannula setup, which would be great for transport. Now, there is some PEEP that goes on, just like there is with CPAP and BiPAP, but it's going to be on the lower end. But from my experience, what I've seen, because the patients tolerate this so much better, it's so much more comfortable that they do so much better with it. You're still going to recruit the alveoli. You can still improve the oxygenation. You're still reducing the atelectasis. It's not the same as CPAP, but provides some physiological support. And this is one of those things that making people comfortable with. People don't like masks very well. I've had people complain about a mask because they couldn't wear their glasses, therefore they couldn't see the TV, that type of thing. But this here, with just the cannula in, they're just a lot more comfortable and tolerated better. So improved humidification. I can tell you, somebody like me, I always have a dry mouth because I'm a post-cancer patient. Put dry air on me would be miserable. For these people, they have control. So it preserves the mucociliary function, so they're able to clear their airways better. Dry airways get clogged up, should we say, a lot easier. So it prevents the drying, improves clearance. Trying to suction people and try to clear airways obviously is a big deal, something that you're going to have to be proficient at. These patients that are on these types of devices, whether they're ventilators or high-flow nasal cannula or CPAP, BiPAP, suctioning and clearing the airway is a common thing that needs to be done. And it's not always our favorite thing to do that. So reduces bronchospasm triggers because of the humidification and the warming. Dry oxygen increases airway resistance. We end up having the narrowing and the swelling that occurs with this. So we're going to have a lot more resistance. Less suctioning, better spontaneous airway clearance. So if I've got somebody that I'm humidifying and I'm warming and that type of thing, they're going to be more comfortable. We can clear airways easier and that type of thing. And so it comes back to a more comfortable therapy. So what we're looking at is reduced work of breathing because of that dead space washout, stable FiO2, mild PEEP. It reduces airway resistance, increases make it less work, and it prevents intubation. That's what the studies show. If we get somebody started early, and you know as well as I do, patients for regular EMS calls don't call it the first sign of a problem. If they did, some of these patients would not be traveling the pathway that they're going, but that's what the world is. And so the sooner we can get this type of therapy working on them, I don't see this being used in routine EMS. Definitely would be a great advantage for critical care transport. So improve oxygenation, improve ventilation, reduce work of breathing, and if I can do all that, the three things that every device should do for you as the clinician, it should make your job easier, make your job safer, and improve patient care. This is the type of option that I would like to have if I'm transporting patients or treating patients. This is something else that I can have in my bag of tricks of what I'm going to do so I don't have the dyssynchrony between therapy and the patient's condition. You know, this thing of what one size fits all just really doesn't come into play. Now, this is something that was written in 2020. Patients with severe acute hypoxic respiratory failure who tolerate high-flow nasal cannula present a significantly lower need for intubation compared with conventional oxygen therapy. That's a big deal when we're talking about survivability and we're talking about length of stay, all the big things that these hospitals look at now. Does the patient end up getting admitted to ICU versus being admitted to the floor? Yeah, those are all big issues in our healthcare.